This is just another one of my beautiful grandchildren modeling the pediatric TLSO. The first one is the vertebrae TLSO. The middle one shows with the hyperextension stop, and this would be excuse me, for patients of any age who have suffered some type of brain injury that causes them to have upper extremity extensor tone. This is basically from waist up, they're firing up and back. And it's unfortunate that you many times find these people in a reclined chair because someone's trying to make them more comfortable, but that actually can feed the tone and make it worse. I remember a lady who was mid-50s and had had a heart attack. She was the CEO of a company, a very active lady, and she'd had a heart attack, and when your blood slows, again, one of those mechanisms your body's trying to do to always keep itself regulated, it thinks it's supposed to clot. So then she formed a clot and it went to her brain and she had a stroke. And when I first met her, was in a nursing home, and she was in a reclined chair, and she had this wild look in her eyes, and she was going, "Put me to bed, put me to bed, put me to bed." I can't speak as fast as she did. It was rapid fire, but she was saying, "Put me to bed. I'm falling, I'm falling, I'm falling." And this horrible look of fear on her face. So we got her into bed, out of the chair, and until she was totally flat on her back, even without a pillow, she was just all tense. And once she was totally flat with her head down, she started to calm down a little. And then, in about 15 minutes, she could speak fine. But what we did for her was this device, and knock on wood, every one that I know of that we have come in contact with has been very successful. And it's like the pictures that you just saw of the little girl in China. Once you get that 90-degree pelvic tilt, the hips, the torso, and the thighs in 90 degrees at the hip, that relaxes that tone in the upper torso. And with patients with that extensor tone going back, keep them at 90 degrees, and this hyperextension stop extension that comes up out of the back of the TLSO will bring their head into alignment, maybe a little bit farther forward, and that will keep that tone at bay. If you prevent the tone, you continually relax the tone, then you prevent the deformity, the shortened tissue, and they're able to lead a normal life. They'll have trouble speaking, they'll have trouble concentrating, and it's amazing once you reduce that tone, if their cognition is still intact, you may see amazing improvements. The picture on the right, again, is the vertebrae TLSO with a safe serve right for a pediatric patient. This is Rachael. Rachael lived in another state, and she had a very caring husband. This is a picture that was on the wall of Rachael before she became pregnant. She was pregnant and was about a week before 40 weeks. Babies should stay in mom ideally for about 40 weeks. She was 30 or 35 weeks, and she ended up having a stroke. She went into a coma. They took the baby's fine, little boy, but she had some significant after effects. You can see here, she and her husband had a very active life. She tried to stay healthy. This is just something that happened to her. She had been in the coma for about 30 days and then coming out of the coma for about a month when I met her. You can see her elbows are stiff in extension, hands not terribly severe, but they did have some contractures, some tone issues. Hips pretty good, knees pretty good. She had torticollis at her neck. But the interesting thing about her great toes in the second picture, you'll see were in hyperextension. They stuck up at almost 90 degrees from her feet, which again is fascinating, that where this brain injury that she had from the stroke, how it ended up causing hyperextension of just her great toes and no other. She had not been out of bed except in a reclining chair, and they were kind of afraid to get her up. So I took what I anticipated that she would need, and we said, today's the day. Rachel's getting up. Her husband was so supportive. He had actually talked his employer into letting him move his part of his workload into her room. So he stayed with her almost 24 hours a day. So it was just the nursing home there, their hearts just went out to this young couple. The baby was being well cared for, but it was a wonderful experience to meet Rachael and be able to be a part of her care. But there was just a little chair like you would have in your living room that we pulled over and put her up in it enough that she could get that 90-degree pelvic tilt, that hip flexion. We, of course, had already log rolled her onto the back of the vertebrae's TLSO, put the front on, sat her up, put the shoulder straps on, attaching in the back, and then put the headpiece on. Now her head went to the right, so she was fit with a safe serve right, and it allowed her to work through that flexion. Well, her mom and dad came in right after we got her up, and the mother remarked at the spark in her eye that they had not seen. Rachael was a little irritated because we were getting her out of her comfort zone. She had been like this in bed for long enough that her body thought this was normal. And you know, it's kind of like if you're learning to play a sport, let's say golf, and you have a problem with your swing, well, you can go to the pro and take lessons. He will give you exercises to do, and unless you continually do those exercises enough to create new muscle memory, when you get up to the ball and actually aim to strike it, you're going to fall back into your old habits because that's where your body thinks it should be. So just like that, with our patients, we have to change their position enough that the body goes, oh, this is where I'm supposed to be. So with her posture and all, but I want you to look at her elbows. Do you remember in the first picture, they were straight out and stiff? And just by getting her up after a few minutes, we were able to flex her elbows somewhat. So they should, with her only have had the brain injury for 2 months prior, she should do a nice job of being able to bring those elbows back up. Now we do, if we need to, we can fit her with hyperextension elbows, and they will continue to bring her hands up. It's vital that, you know, somebody might say, well, why would you do that? Well, if you have any hope of being independent with your own activities of daily living at all, you have to be able to get food to your mouth, to brush your teeth, to comb your hair, to rub your eye, all the things that we do every day and never think a thing about it. These patients have to be able to bend their elbows enough that they can do that. Fit her with safe boots, safe boot 2s, but her toes were still up. So when I got back to restorative medical, we made little soft straps that would go across her toes and Velcro to the bottom underneath her boots that would start to gradually bring the toe down. Remember, we don't just push it down because that's tone holding it up. We want to gradually allow her toe to work through that tone and relax on its own. If there's any shortened tissue there, in a couple of months, probably not, but there might be some starting, it might be stiff. Then we want to just gradually bring that down, nothing abrupt. But you can see her from the side, how her body alignment was just much improved. The good Lord didn't make our bodies to lay down. And when you are immobile, everything starts going wrong with every system of your body. We have a lot of diabetes today, and certainly in this country. When you're immobile, your blood sugar naturally goes up. Your metabolism slows. The heart doesn't function as proficiently as it should. The tidal volume of your lungs shift. You're not taking deep enough breaths that you get out that moisture and suck in good oxygen. You're not getting that good carbon dioxide oxygen exchange. All these things go wrong. We see pressure ulcers. We see contractures, but everything inside the body starts to go amok. So at the very least, we want to get people up in good 90-degree hip flexion. If they can get there and we don't have contractures of the knees or feet, or that we can correct those, then let's put them in a standing frame and have them stand up on those long bones. And my goodness, just to be able to stand up in good posture rather than lying or sitting. And the weight bearing on those long bones is vital to maintain that bone integrity, to maintain the minerals in the bone, that we continue the osteoblast cells to rebuild that bone and to keep it strong. Again, we're going to empty our bladder rather than being in bed and it not emptying. You have to have that good tilt. So get your patients up, keep them going up. If you can stand them up, can they take a step? If they can, ambulation training, maybe they can walk.